Hello everyone, I'm back, and this is a continuation of our synchronized cardioversion. This is a defibrillator monitor, and which has 4 functions here: basic monitoring, synchronized cardioversion, defibrillation, and pacing. Okay, and we have also here an anterolaterally located pads, defib pads or patches on the patient. And we have here a case study of a 55-year-old male, short of breath on exertion, a heart rate of 180 beats per minute, wide complex tachycardia, blood pressure 72/30, ECG 12 leads revealed a monomorphic VTAC. And here we got here a right bundle branch pattern here and the V1. And we have also an RS on the V6, which is conclusive of monomorphic ventricular tachycardia. And this patient has a pulse. Okay, and chest x-ray revealed an evolving or starting pulmonary edema. The cardiologists have seen the patient, talked to the patient, assessed, discussed the plan, and ordered a stat synchronized cardioversion. And our team here involves the cardiologists and the CCO-RNs. Okay, so here we go. We have the pre-cardio version, which is a synchronized cardioversion here. So what will the RNs do? We work as a team, of course. Okay, we have to explain the procedure and, the preparation to the patient. We have to shape the chest. There might be hair, so we have to remove it. This is for the patches to be applied. And start ECG 12 leads. We have to have a baseline of the 12 lead ECG before the procedure. Rhythm strip to be used by the nurse's notes on her charting. And we have to start normal ceiling KVO. 2 sides will be okay, but if 1 is good, that's fine because we're running quite short of time. We want to eliminate this rhythm. It's not good. Okay, the crash cart is with the patient. There's a defib monitor and medication. We attach the patient to those leads and the pads are already there. There's an ambu bag in case something happens. We have also the cardiologist to decide whether he likes to give sedation or not. And then the RN assigned to the patient will continue her documentation and updating her chart. And in case everything done as a pre-synchronized cardioversion, then other RNs are standby, but it's not over yet. Okay, with regards to the synchronized cardioversion actual, what will the RNs do? So either the cardiologist will say he will be the one to do it, or he will direct the CCO-RN to do it. Okay, so they are in the room. We are in the room with the patient, with the doctor, okay, and our co-staff. So in here, there are numbered here. Number 1, we have to press the on button. Okay, to turn on the machine, defibrillator machine, we have to turn on the button by pressing the on button. We press the sync button or the sync mode button. We got also to press the energy. Usually when we start to synchronize cardiovert on monomorphic VTAC with pulse, we all start with 200 joules, and then the press charge, and then we say all clear, and then press and hold the shock button until the sensor will be able to capture the best QRS, the best R wave of a QRS, and deliver the synchronous shock time with that R wave. Okay, and the nurse in charge to that patient will continue her documentation and update her chart. Okay, so here we go. If I go up in here, so to sync cardiovert the patient, we have to start to turn on this defibrillator machine by pressing the on button, and then that's number 1, and then we press the sync mode button in here because we have to sync cardiovert the patient, and then the energy select, it's 200 joules usually for monomorphic VTAC with pulse, and then the charge, and then we start to say, okay, all clear, nobody will touch the patient, nobody will touch the bed, and the oxygen blowing on our face will be shut off because this procedure will take very fast. And then also keep an eye if the operator of this sync cardioversion will be stepping on a liquid or anything, be sure everything is safe. Okay, and then when said all clear, so then we will press the what you call this one, we will press and hold this shock button until the sensor of the defibrillator monitor will be able to sense a good R wave and deliver the synchronous shock time with that R wave, or synchronize with that R wave. Okay, and then everything succeeded, so we were able to get the the original rhythm before the before the VTAC episode, and then the nurse assigned to the patient will continue to do her documentation and charting. Okay, so here we go. So again, we have the 12 lead ECG before the procedure. That is the monomorphic VTAC with pulse in here, and then here is the part where we apply the synchronous cardioversion. So you see that all these R waves are flagged, or these are all marked with an arrow, and they are pointing all to the R wave of the QRS, and the sensor will pick up the best R wave to deliver the synchronous shock time with that R wave. Okay, and the machine will either be biphasic or monophasic in here, deliver the shock in here, and successfully converted the patient to his or her original rhythm in here. Okay, so with this success, post-cardioversion, what will the RNs do? If that is a success procedure, either to their original sinus rhythm, or it could be different one, or controlled AFib or anything, as long as it's not the VTAC. Okay, so we will do again a 12-lead ECG post-cardio successful synchronous cardioversion. We get the rhythm strip for the assigned RN to her nurse's notes. We will continue. Actually, we still continue to work as a team, but the main player now is the nurse in charge to continue to assess and monitor the patient, and then documentation and updating the chart. Okay, so anyway, if you think that this synchronized cardioversion failed, there is a problem. It might possibly happen. Okay, so assuming that the patient is supposed to have a synchronous cardioversion, but they failed to hit the sync button. Actually, what is happening now is that we're not doing any more synchronous cardioversion, but we're actually defibrillating the patient. The other name for defibrillation is asynchronous cardioversion. The one that we hit the R wave time with the machine because of the sensor is the synchronous. So synchronous, the patient is with pulse, okay, and that is time with R wave. Defibrillation or asynchronous is that you just hit that shock button, and right away the electricity will get in. So this is what's going to happen. Okay, we have a rapid atrial fibrillation that is supposed to be sync cardioverted. Okay, so they forgot to press the sync button, so they deliver the shock. Actually, it is the defibrillation shock that they delivered, not the synchronous cardioversion. And look what had happened here. Right away, once you press the shock button, you deliver the shock or electricity right away, and hit regardless of that QRS. And so this time it hits the T wave accidentally here, and the patient right away went into ventricular fibrillation. This is more like close to fine ventricular fibrillation. This is what's going to happen. So the patient will go into cardiac arrest. And if this thing happened, don't waste the time. Just go and defibrillate the patient. Okay, but I'm saying it might possibly happen that somebody might have forgotten to press the sync mode, and this is what's going to happen. So we have to be very careful and to see that, Okay, so again, if we go back, so in cardioversion, all we have to do, we have identified, that's why we do 12-lead ECG. We have to identify what is the 12-lead ECG that reveals monomorphic VTAC. Okay, we have that already. And then once it is there, there's pulse and everything, we're ready for sync cardioversion. We'll start again. So we have to turn on this defibrillator monitor machine by pressing the on button. And next, we have to go and press the sync button. Next, we have to go to the energy select, which is actually 200 joules for monomorphic VTAC. Okay, and then we have to charge it. Okay, once you charge this one, you see to it that everyone is, we sound the word clear for everyone.